Good evening, everyone, and welcome to the Antenatal Share Care Obstetrics Update for the RPA in Canterbury webinar. I'm Kylie Somerville, the Population Health and Chronic Disease Program Officer with Central and Eastern Sydney PHN. Also with us tonight from CESPN is Lauren Thomas, the CPD Program Officer, and Dr Natalie Caristo, one of our Antenatal Share Care GP advisors, will be facilitating the Q&A. I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and pay respects to elders past, present and emerging. I'd also extend that respect to any Aboriginal colleagues who may be joining us tonight. Just some general housekeeping. At the end of the webinar, the evaluation survey will pop up on your screens. We really appreciate your feedback, so please complete this to allow us to issue certificates of attendance. Please ensure that you submit your questions to the speakers in the Q&A function throughout the presentation. To view this box, you hover over the toolbar at the bottom of your screen. As always, here are some coronavirus resources. Please visit the CESPN website for more information. If you'd like some digital health resources and information, please check our website or contact our digital health team. The Domestic and Family Violence Assist program supports health professionals to recognise and respond to signs of domestic and family violence in their patients. Mental health support can be found via New Access and Head Start. If you need some more information, please visit their respective websites on the screen. Project GROW provides support for health professionals to provide more effective care for people with intellectual disability. Please visit the GROW website. Central and Eastern Sydney PHN have also produced a comprehensive services guide outlining the services we provide and those that are funded. Please visit the website for more information. Head to Health is a free service open to anyone experiencing mental ill health. To access the service, please call the number on the screen. As this is the last year of the triennium, please note that you need to meet the education requirements for the Antenatal Share Care program. If you're unsure of how many points you have, please contact the team at ansc@cespn.com.au. I'd now like to introduce our GP facilitator for today. Please welcome Dr. Natalie Caristo.
Thank you. I'd like to introduce our first speaker for tonight, Dr. Arianne Sweeting, who will be presenting on thyroid conditions in pregnancy. Dr. Sweeting is a staff specialist endocrinologist at Royal Prince Alfred Hospital, Sydney, an NHMRC Early Career Fellow in the Faculty of Medicine and Health at the University of Sydney, and the 2021 Australian Diabetes Society Skip Martin Fellow. She's also a researcher within the Sydney Local Health District, Sydney Institute for Women, Children and their Families. Please welcome Dr. Sweeting.
Hello everyone, thank you for that introduction. So I will be presenting on thyroid conditions in pregnancy tonight, and I would like to acknowledge my colleague Dr. Ash Gargia, who's previously presented this but was unable to do so this year, and I'll have stepped in, but these are his slides. All right, so the outline of the talk today, we'll be considering the physiology, prevalence and recent guidelines by the American Thyroid Association. We'll also be examining preconception or pre-existing thyroid autoimmunity, hypo and hyperthyroidism. And then we will look at pregnancy-specific hypothyroidism and hyperthyroidism, and finish, if we have time, with a brief discussion on thyroid nodules and cancer in pregnancy. So moving to physiology, prevalence and guidelines. So this graph illustrates essentially beta-HCG profile in pregnancy, and alongside that you can see the increase in total T4, thyroid binding globulin, as well as free T4. Concurrently, as the beta-HCG peaks in early pregnancy, you have the suppressive impact on the TSH level. And it's thought that this could be an evolutionary reason for this, that the increased placental HCG essentially serves to increase T4 production to ensure adequate supply to the fetus for neuronal migration and proliferation. Alongside that, you can see that the fetal dependency on maternal thyroxine is complete in early pregnancy. And by about week 18, 19, when the thyroid, the fetal thyroid is fully developed, the fetus begins to make increasing amounts of thyroid hormone. Later pregnancy, we get this increase in T4 degradation by placental enzymes and increased iodine clearance. But at that point in time, the fetus is autonomously producing thyroid hormone, and therefore there is more scope for that to occur. Another point to make when we consider the physiology of thyroid hormones is that there's multiple mechanisms in which we are able to achieve an increased production of thyroid hormones to ensure that there's enough for fetal neuronal development. So we know that thyroid hormone production needs to increase by approximately 50% in pregnancy, and there's a recommended iodine intake of about 250 mics a day. So we have the HCG effect that we've already spoken about, which has a stimulating impact. And so then we also have a high estrogen level, which leads to increased TBG concentration, and various other mechanisms, including increased deodination of T4 and fetal acquisition of thyroid hormones, which essentially will all serve to increase the production of thyroid hormones and ensure that there's sufficient substrate for the fetus. Similarly, we have the fetal acquisition of iodine to produce its own thyroid hormones and increase renal clearance of iodine, which means that we are using maternal iodine substrates, and then we have an increased need for maternal iodine intake to meet this demand. The final point regarding thyroid physiology in pregnancy is transplacental transfer of either thyroid hormones or medications, and I think this is quite helpful to feel comfortable with. So TSH, HCG, and thyroglobulin do not cross the placenta. TPO antibody and TG antibody, so thyroid peroxidase antibody and thyroglobulin antibody that correspond with Hashimoto's, do cross the placenta, but they do not affect fetal function, thyroid function, and we know that the degree to which T3 can cross the placenta is still not understood. However, in this graph, you can see that T4 and levothyroxine, or I'll just say thyroxine medication, do cross the placenta with impact on the fetus's brain, bone, and thyroid, and that's important considerations. It is evident that the TSH receptor, or the TRAB antibody that correlates with Graves' disease, does cross the placenta, and depending on whether it's a stimulating or blocking antibody, can have specific effects on the fetal thyroid gland. Iodine also crosses the placenta, and so that is relevant in the setting of maternal iodine deficiency. Radioactive iodine, of course, then also crosses the placenta, and that is why we have recommendations for no pregnancy for at least 6 to 12 months following radioactive iodine. And in terms of medication, and we will discuss this when we look at hyperthyroidism in pregnancy, both PTU, propylthiouracil, and methimazole, which I'll refer to as carbimazole subsequently, do cross the placenta and have an impact on fetal thyroid function. Finally, propranolol, which we'd use for symptom relief in hyperthyroidism, does cross the placenta, but is thought to have mild impact. So moving on to the prevalence of thyroid disease now. In women of reproductive age, so not pregnancy specific, but reproductive age, the presence of thyroid autoimmunity, so that could be TRAB, TPO, or TG antibody positivity is in the order of 11%. Specifically relating to hypothyroidism, it's up to 3%, and hyperthyroidism up to 2%. And to note that thyroid cancer is the most common cancer in women aged 20 to 34 years. We do know that both Graves' and Hashimoto's disease is associated with reduced fertility in the order of about 50%. In pregnancy, overt hypothyroidism, so elevated TSH with reduced T4 and T3, is around a prevalence rate of about 0.5%. Subclinical hypothyroidism with a low TSH and normal free T4 and free T3 is in the order of 3.5%. Isolated maternal hypothyroxinemia, so that's the isolated low free T4, is in the order of 2%, but is quite a problematic diagnosis, and we'll get to that too. And that is limited to iodine sufficient populations, that prevalence data. Overt hyperthyroidism is under 1%. Subclinical hypothyroidism, of which there's several etiologies in pregnancy, can be up to about 2.2%. Throughout all this data that I'm presenting, it will be important to note that we're using a population-based screening with a 97.5 centile TSH cutoff for hypothyroidism. So that upper limit of the population-specific reference range. Okay, so what should the upper limit of TSH be? I'm sure you're all familiar with the 2011 American Thyroid Association guidelines, the European Society and European Thyroid Association guidelines also. So they recommend that when we're defining the upper limit of TSH and therefore hypothyroidism, we're looking at population-based and trimester-specific reference ranges for TSH and free T4 in TPO antibody negative women. Right, so that's the ideal, that you look at your population, your local population, and then you calculate what the upper limit and lower limit should be based on that mean distribution. If unavailable, they set a fixed upper TSH limit of less than 2.5 in the first trimester, which can be relaxed to 3 in the second and third trimesters once the fetus is independently making thyroid hormone levels. Then we had the 2017 updated guidelines, which again say the gold standard is using your population-based and trimester-specific reference ranges. But if unavailable, they'll set a higher threshold target of 4 for the TSH. So how was this data developed and these guidelines developed? So a couple of things to look at here. So if we just look at the population prevalence of overt hypothyroidism in this diagram on the left, you can see that if we do a true 97.5 percentile of that's the upper limit of TSH, then you would define overt hypothyroidism in about 0.5%. If you use that 2.5 mil cutoff, however, the prevalence increases to 1.33%. If you use a TSH of greater than 4 cutoff, you're getting down to about 0.8%. What that correlates to is an overdiagnosis in 1 in every 120 women, if you have that TSH upper limit of around 2.5, and 1 in 334 women if you set that threshold of 4. For subclinical hypothyroidism, the potential for overdiagnosis with that 2.5 is much higher. So again, we have subclinical hypothyroidism. It's more prevalent in the population with about, let's call it 3.5%. If you set that target of 2.5, you get up to almost 15% of women could be diagnosed with subclinical hypothyroidism. If you limit it to a TSH of greater than 4, you can see that the prevalence is much more comparable to that gold standard upper limit of a population reference range. So you end up having an overdiagnosis in 1 in every 9 women. But if you set that threshold at 4, the overdiagnosis occurs in only 1 in 167 women. So that way of thinking has essentially led to the treatment recommendations in pregnancy, and it's stratified according to whether women are TPO antibody negative or TPO antibody positive. And we'll look at this in a little bit more detail for TPO antibody positive women later in this presentation. So take-home messages would be that in TPO antibody negative women, you are going to have in your normal population, if they're at the upper limit of normal and you've calculated your TSH range based on population-specific data, you could commence thyroxine therapy. Alternatively, once that TSH is 4 or above, you could commence thyroxine therapy. And certainly if you're in the overt hypothyroidism range at greater than 10, you should be commencing therapy. In TPO antibody, there is a lower threshold for commencing therapy. And that would be, again, around that upper limit of normal, or essentially around that 2.5 mark. Okay. The euthyroid TPO antibody positive women preconception, they suggest not initiating thyroxine prior to pregnancy, but you could instead monitor the TSH every 4 to 6 weeks until mid-gestation to determine whether they do in fact require thyroxine in pregnancy. Other considerations would be if you have a TSH that is already at that upper limit of normal or just above by about 10 to 12 weeks of gestation, when you'd be expecting that HCG suppressive effect on the TSH to be at its highest, that might be when you'd already recommence the thyroxine replacement therapy, or in someone with recurrent miscarriages whose TSH is within that normal range, but they've got TPO antibody positivity with recurrent miscarriage. Okay, so we'll move on to the next topic, which is preconception, or essentially pre-existing thyroid autoimmunity, hypo and hyperthyroidism, and what we should be doing in this setting. Okay, and so this graph here is essentially trying to demonstrate the principle that at any given point in pregnancy, the TSH level, if a woman is thyroid antibody positive, tends to be higher relative to a woman who is antibody negative. And there seems to be some type of blunted response to the HCG in women with antibody positivity. As a side note, you can see that thyroid antibody profile being higher early on, then decreasing and higher at the end of the third trimester. And so I think this is quite useful when we're considering the rationale for why we might have a lower threshold to treat women with TSH even being marginally elevated in the setting of TPO antibody positivity. So thyroid autoimmunity, so positive thyroid antibodies in a hypothyroid, so TPO antibody or TG antibody positivity. It's associated with, but again, does not imply causality, which is being a problem with several of the thyroid studies, as it appears to be an increased risk of sporadic miscarriage and preterm birth, sort of double the risk, but no apparent effect on assisted reproductive therapy, essentially success of that. The mechanisms don't necessarily appear to be specific to the thyroid disease itself. So it might be it's being postulated, increased maternal age or thyroid hypofunction and the actual impaired thyroid response to the HCG. It could be because it's a marker of generalized immune imbalance, and there might be associations with reduced oocyte quality. Okay, so then the question then becomes, when we intervene, do we improve outcomes in euthyroid women with TPO antibody positivity? So, and this is in the preconception period, and then we'll look at the data for in pregnancy as well. So the Postal study in 2017 essentially commenced low-dose thyroxine therapy. You can see that the intervention versus placebo group had similar TSH levels that would be within a normal reference range, reasonable numbers in both groups, but a single center study. And they showed that there was no difference with respect to miscarriage, pregnancy, or live birth rates. And again, interestingly, no difference in the outcomes if you stratified it according to the TSH threshold. And then we had the tablet trial, and I'll just add the T4 Life trial as well. So take-home message is preconception, thyroxine initiation, no difference in miscarriage risk or live birth outcomes. And the key studies here are looking at the tablet trial, which again was a multi-center UK trial, similar rate levels of the TSH. They had a history of miscarriage or infertility and no difference. The T4 Life trial, I just quickly looked it up before I presented, and there's been a recent 14th of March 2022 in the Lancet Diabetes and Endocrinology, where they have commented that they ultimately stopped the trial early once they had about 78% recruitment due to slow recruitment, and they essentially demonstrated that there was no difference in birth rates and was still sufficiently powered to assess that in euthyroid women with TPO antibody positivity and recurrence and more than 2 miscarriages. So European populations, predominantly Caucasian populations, I should note. This graph here is essentially demonstrating that even if you're looking at subgroups, there's no difference. Okay, So what about if we commence the thyroxine therapy in pregnancy rather than pre-pregnancy? I think intuitively you can guess that there wouldn't be a difference, and that has held true in the Negro study, which commenced thyroxine and it was titrated to weight, initiated in the first trimester. They also it was single center, they also included a control group, and they showed no difference in the rate of miscarriage or preterm delivery. There is, so group A here, though, when you look at the graph, it does look that is the TPO antibody positive women plus medication, and then group B was TPO antibody positive but no medication. It did look like if you didn't commence medication, you did have a higher incidence of miscarriage and preterm delivery, but it was not statistically significant. Okay. So moving on to pre-existing preconception hypothyroidism. I'm just going to put all this together. So we aim for a TSH of less than 2.5 when we treat. Okay, so that's the target. Once pregnant, we recommend increasing the thyroxine dose by 20 to 30%. That could correspond to 2 extra tablets a week, but up to 50% dose increase if there is no thyroid. So in the setting of people with congenital absence of the thyroid or previous radioactive iodine therapy or thyroidectomy. Would recommend repeating the TSH within 4 weeks of dose adjustment in early pregnancy. Less frequently is needed in later pregnancy. And for hyperthyroidism, would recommend not treating subclinical disease, and you define that based on the TRAB antibody positivity or not. Okay, so for Graves' disease, definitive therapy is preferred preconception, and within that, surgery is probably preferred than radioactive iodine therapy. In terms of medications, we'll examine this in more detail. We suggest switching the carbimazole to PTU at least 2 to 4 months pre-conception and maintaining on low dose therapy because of teratogenicity data that we'll come to. It's important to maintain the free T4 in the mid to high normal range, and ideally that the woman does not fall pregnant until the TRAB is less than 10 or as close to normal as possible. For toxic nodular disease, definitive therapy again is preferred preconception and again surgery to radioactive iodine. Okay, so we'll move on to pregnancy now and hypothyroidism in pregnancy. So in terms of overt hypothyroidism, it is very clear that there's an increased risk of pregnancy complications, including small for gestational age, preterm birth, gestational hypertension and preeclampsia, gestational diabetes and postpartum hemorrhage. From a fetal perspective, there is evidence, and it's controversial, but it's there, that there is a 7-point IQ deficit at age 7 to 9. That's based on the Harrow study, with delays specifically in language, attention, and motor development for overt maternal hypothyroidism in pregnancy, and potentially increased mortality. But it's important to note that here in this setting, it is known that there is effective treatment with thyroxine in terms of clear improvement in fetal-maternal outcomes. For subclinical hypothyroidism, and questioning, well, does thyroxine in this setting improve outcomes? We do know that subclinical hypothyroidism is associated with miscarriage, but there's conflicting results regarding preterm delivery. So what we see is, for example, looking at the Maracas study, which was a large US retrospective database, that over 5,000 women with subclinical hypothyroidism, but again, you can see that TSH range, and it tends to confound many of the studies that you're certainly into the overt range there as well, with a small percentage, 16% on thyroxine. They showed that the thyroxine therapy was associated with a reduction in miscarriage only if the baseline TSH is greater than 4. So you can see that with the pregnancy loss here, that once you've got that TSH of greater than 4, you have a 55% reduction in risk of pregnancy loss, and that was significant, with no significant difference for a TSH below 4. In terms of another study, which was in, 2 RCTs based in Iran, again, defining subclinical hypothyroidism based on the more stringent 2011 guidelines. They started thyroxine in week 12. And they're showing again that in TPO antibody positive women on thyroxine therapy, that you will reduce your risk of preterm delivery, but it's only significant when you do the post hoc analysis when the TSH is above 4. Okay. Similar for the subset of TPO antibody negative women with subclinical hypothyroidism and thyroxine, that a TSH above 4 is associated with just a statistically significant reduction in preterm delivery. But again, note in this study that was a very small number of women. Okay. And then just briefly, there was a meta-analysis which confirmed that there was a reduced risk of miscarriage if thyroxine therapy was initiated prior to the commencement of IVF therapy. But note again that, these baseline TSH levels in these women are really relatively high, I must say. Okay, so a quick case now, just to orientate ourselves to all that data. A 33-year-old woman who is 7 weeks gestation, her TSH is just at the upper limit of normal, so depending on what your reference range is going to be, 3.5 with a normal free T4, and she's TPO antibody negative. What would you do? You would not need to treat in that setting with thyroxine, and you would not need to repeat or monitor the TSH. But alternatively, if you have that same situation, but there is TPO antibody positivity, you may consider the benefit of thyroxine, but there is no clear evidence for benefit. And if you do commence, you'd set that threshold of 2.5. That's got to be your treatment threshold once you commence. And you would also need to monitor the TSH every 4 to 6 weeks till mid-gestation. All right, what if we had a woman with a TSH level now in the higher range? So at 6.5 with a normal free T4 still, you would initiate thyroxine therapy. In terms of what dose you should initiate, we can see that we've stratified this based on what the TSH level is. The thyroxine dose is always weight-based by mics per kilo per day. In addition to the higher the TSH, the higher the dose. And that is equivalent, essentially, you're getting from about 50 mics for a TSH that's borderline, up to about sort of 200 mics for an elevated TSH that's greater than 10. You want to bring that TSH down quickly. You can always cut down if you need to later in the pregnancy. You'd monitor the TSH every 4 to 6 weeks and every 8 weeks till term in this setting. And then what do we do after the baby is delivered? I think this is particularly relevant. So at RPA, we'd recommend that if the TPO antibody is negative, you can stop the thyroxine at term at delivery. But if the TPO antibody is positive, we continue, okay? Unless the woman is on a very low dose of thyroxine, less than or equal to 50 mics. And I have to say I'd find that quite unusual at that time, unless it's been commenced in the setting of IVF therapy. Unusual because of the gestational weight gain and the increased requirements, women would be on slightly more than that by the end of term. But if they are on that low dose, you can stop. If they are on the higher dose, we'd recommend halving the thyroxine at term and then continuing postpartum. And we also say that it is imperative to monitor the TSH at 3, 6, and 12 months postpartum for postpartum thyroiditis. And the postpartum thyroiditis is most likely to occur or be in that hyperthyroid phase at about 3 months, lasting for about 3 months, having a rebound hypothyroid phase and then normalizing subsequently, hopefully. And then annual TSH because of the long-term risk of hypothyroidism. Okay, so just briefly, thyroid hormone and brain development. We have touched on this previously, but this is relevant when we look at some of the subsequent data. We know that thyroid hormone is essential for early brain development. And we know that if we attain preconception iodine sufficiency, we'll reduce the risk of impaired neurocognitive development. So the placental transfer of maternal thyroid hormone is depicted here, that it's particularly critical at the start of neurogenesis at week 5 until you have a fully functional fetal thyroid gland, which occurs between weeks 18 to 20. And that earlier graph I showed you that there is evidence of fetal thyroid hormone production slightly earlier to that 18 to 20, but really this is the critical time where we need to ensure that there is adequate maternal thyroid hormone. So the CAT study was looking at the effect of thyroxine therapy for subclinical hypothyroidism and isolated maternal hypothyroxemia on offspring IQ, because that was always the major issue that we worry about with the offspring. And I think I'll just summarize, I probably won't do it justice, but I think the take-home message for this is that whether you have the subclinical hypothyroidism or the isolated hypothyroxanemia, that whether you treat or you don't treat, there's no difference in IQ levels. Okay. And similarly with the NIH multi-center study, a large, almost 100,000 pregnancies screened at less than 20 weeks. And they were looking at women with either conditions. They randomized each of those to treatment versus no treatment. And again, there's IQ testing by age 5. There's no difference. Okay. But the caveat to interpreting these types of studies is that if you look at when the cats in the NIH study implemented the thyroxine therapy, it's really relatively pretty late in the piece. Okay, so 13 weeks for cats and 17 to 18 weeks when arguably you already have the fully functional fetal thyroid. So really the question and the study that needs to be done is looking at the impact from earlier in pregnancy. And we just don't have that data definitively yet. Okay, some brief notes about isolated maternal hypothyroxanemia. It affects about 2% of pregnancies. It's defined as a low free T4 in the less than 10th centile with a normal TSH. But you know, the big point to make is that all these studies have used immunoassays in pregnancy with different types of cutoffs, and it's highly problematic. And you know, I think practically, if I'd see that at RPA, I'd often see it consistently in a pattern, and I'd actually think it's probably an assay issue. Okay, if these women are having normal TSH, and that you can often see a trend where there's a large number of women coming through with that T4 at that lower limit of normal. And the first thing that I'd still do was look at what's happening with our assays. And obviously it is a real condition too. Multifactorial etiology, summarized here. I won't go into it now. Yep, no consistent association with adverse pregnancy outcomes. So I would not treat. Some other studies, association studies, have shown some adverse neurobehavioral outcomes, but still we haven't shown that actually treating makes a difference. So moving to hyperthyroidism in pregnancy. So overt hyperthyroidism, so low TSH, elevated T4, T3, affects up to 0.4% of pregnancies. The majority of women with maternal hyperthyroidism are going to have Graves' disease. Other less common causes include HCG-mediated thyrotoxicosis. So you see that. So when we see these women with abnormal thyroid function tests in first trimester, you know, the first question I'm going to ask is there significant hyperemesis? Is it a twin pregnancy? And then you've also had the toxic nodules or thyroiditis and a molar pregnancy less rarely. And you basically work out what you're dealing with by the clinical presentation and, of course, measuring the TSH receptor antibody. So it's certainly true that overt hyperthyroidism is associated with significant pregnancy complications, including miscarriage, IUGR, preeclampsia, preterm delivery, at your worst case, a maternal thyroid storm with the risk of pregnancy loss and fetal thyroid dysfunction. The maternal TRAB, as we mentioned before in that placental slide, does cross the placenta and stimulate the fetal thyroid, in addition to the hyperthyroidism causing potential cardiomyopathy in the fetus as well. So how do we treat? As we mentioned, the preferred treatment is definitive treatment, so surgery and radioactive therapy prior to pregnancy with a safe time to uptitrate thyroxine therapy to make sure that we are within target. The alternative is antithyroidal drugs, but there is certainly a higher risk of fetal birth defects for both PTU and carbimazole. So you can see here, and we'll go into this, that PTU exposure appears to be less of an issue and the defects tend to be milder, so face and neck and urinary. Whereas carbimazole exposure is associated with more and more severe birth defects. So the study by CO in 2018, so almost 3 million Koreans, and they looked at women with PTU versus women with carbimazole and then combined. It was a replication of the previous Danish data, which had shown something similar previously, but also looked at switching and dose dependency. So there's something new here. But if we look at this, you can see that if a woman was only on PTU, she had a 16% increased risk of birth defects, which correlated to a 9 per 1,000 births, mostly genital, urinary, or eye, ear, and face. If a woman was only on carbimazole, methimazole, that was higher, it's almost double, at 31% increased risk. So that is plus 17 abnormalities per 1,000 births, more serious congenital abnormalities involving the nervous and digestive system. If they'd been on some form of both during the pregnancy, the risk was similar to the carbimazole, and that's an important take-home message too. So this slide is attempting just to show that this switching, because what they showed was that there appeared to be no apparent benefit to switching from carbimazole to PTU in the first trimester, which is what we would generally advise. So we'd say, please switch to PTU within that 3 months prior to pregnancy and continue the PTU for the first trimester. And that's the key issue there, ideally throughout the pregnancy, or you could switch to carbimazole if you need to subsequently. So they're trying to say in this data that it appeared to be no difference, but the issue is we don't really know when they switched, okay, the first point, and we don't know whether there would be benefit seen if actually we are meant to be switching these drugs over prior to 3 months. So unanswered question. The final point that this study showed was what is the impact of cumulative dosage? And this is essentially showing that, lowest versus highest dosages here, that for PTU, there appears to be no real difference. But for carbimazole, the cumulative dosage really does make a significant impact here. The higher the dose, the worse the outcomes. All right, so the take-home messages here for drug management for Graves' disease. You ideally limit exposure to antithyroid drugs, in particular during that teratogenic period of 6 to 12 weeks gestation. We strive for preconception definitive treatment if possible. Based on that data, we want to titrate to the lowest effective dose of PTU or carbimazole. And you can consider stopping therapy in women in early pregnancy who are biochemically well controlled prior to pregnancy and on low dose therapy, because in general, you're not going to tend to see that flare of Graves' disease in pregnancy if that TRAB is reasonably well controlled. Cases now, 33, 7 weeks. We know that she has a history of Graves' disease, not on medication, hyperemesis. We have clearly hyperthyroidism here, significant elevation in the T4 and T3, suppressed TSH. Goiter, lid retraction, tachycardic. Clinically, you would be suspecting more Graves' disease, particularly with the history. We won't talk about differential. I think it's quite clear. The TRAB is unsurprisingly significantly elevated at 15. Regarding management, we'd advise PTU, so 50 to 100 milligrams TDS. It would be very strict with that every 8 hours. Otherwise, you get this thyroid escape of the hormones, okay, and you go right back to where you start from, plus or minus propranolol. There is some data suggests IUGR, but as I discussed previously with the placenta, we're quite comfortable with it. You need to monitor the thyroid function test regularly, so even 2 to 4 weekly. Switch the PTU to carbimazole early second trimester. Keep the free T4 high normal. And I think this, or just above the upper limit of normal. For me, clinically, I think this is an important teaching point. You do not want that free T4 to be at that lower limit of normal. You've got to pull back quickly. The T4 has got to be high normal, harking back into what the baby actually needs. So I don't like to see some T4s, 8, 9, 10 in this setting. We're being over treating them, and if that's the case. Then the final point is to check that maternal TRAB at about 22 to 26 weeks to determine the risk of fetal hyperthyroidism. And if the maternal TRAB is still more than 3 at that point, you know that could be a significant issue. And with that, we would do fortnightly fetal ultrasounds looking at the heart rate, the heart, and the growth trajectory and the thyroid. Okay, and then postpartum, the neonatologist would be monitoring the baby. So in terms of how we'd advise postpartum, less than 1% of carbimazole or PTU enters the breast milk. Max dose that we'd recommend would be 20 milligrams a day for carbimazole and PTU 300. So it's actually not that much for someone who might be in overt hyperthyroidism, particularly because we know that Graves' disease will invariably flare in that 4 to 8 months postpartum. And your differential here is it just a postpartum thyroiditis or is it Graves' disease? In which case they would require more than that max dose, to be honest, to achieve normalcy. And so, you know, that's where we'd have a discussion with women about whether we're going to be able to safely continue breastfeeding or the risks and benefits. Okay, so then the alternative differential to be aware of, and we've mentioned this, is early pregnancy, significant hyperemesis. You can see here when you look at the thyroid function that the T4, T3 is just not as high as what you'd see in Graves. It just doesn't go as high. There's no other clinical signs. She's tachycardic, but TRAB is negative. So in this case, it's just, you know, the hyperemesis, the HCG effect in early pregnancy, and it's just hyperemesis, gravidarum management, hydration, antiemetics. Can monitor the thyroid function test regularly until normalized by 12 to 14 weeks. No need for therapy. It will self-resolve. I'll just check the time. I think I've got a couple more minutes. So thyroid nodules and cancer in pregnancy. And based on a case, so 14 weeks pregnant, she has a left thyroid lobe with non-tender swelling. What do you do next? Clinically euthyroid, biochemically euthyroid, you'd perform a thyroid ultrasound and you can see this large, well-circumscribed nodule, which does look benign on the ultrasound appearance. You would do a biopsy, an FNAB. It's come back Bethesda 2, benign. It's very reassuring. And so that case really illustrates what we see most commonly, which is that thyroid nodules and their volume can increase in pregnancy, increase by about 10 to 20%. It is worsened in the setting of iodine insufficiency, and also it's due to the high estrogen levels and HCG stimulation. If we're unlucky enough to have a nodule FNA consistent with thyroid cancer, most likely papillary thyroid cancer, it is okay to offer second trimester surgery, but delaying surgery postpartum does not appear to affect disease-specific mortality. And we would monitor the neck by ultrasound each trimester, so both tumour and lymph nodes. Commencing thyroxine would be appropriate in this setting, and you'd aim for the TSH suppression, which is also what we do with the thyroidectomy, that we're aiming to suppress the TSH. Okay, but do not render overt hyperthyroidism. Okay, so conclusions now. So new evidence, or not so new evidence now, suggests that there's a lack of benefit of initiation in euthyroid TPO antibody positive women preconception. Close monitoring of the TSH every 4 to 6 weeks till mid-gestation when the fetal thyroid gland is autonomous is an alternate option. But thyroxine therapy does appear to be beneficial for women with a TSH greater than 4 in pregnancy, regardless of the TPO antibody status. It's important to maintain adequate maternal thyroxine T4 levels in pregnancy for fetal neurocognitive development. It seems that too high or too low levels may impact child IQ and cortex volume. And preconception definitive treatment of Graves' disease may be preferred due to the teratogenic effects of both available antithyroid drugs. So with that, I will finish my presentation. Thank you.
Thank you so much, Dr. Sweeting. I've just got a few questions, if that's okay. I'll group them together. So there was a group of questions with regards to investigation. So mostly in women with pre-pregnancy planning, should we be doing thyroid antibodies? What about screening for iodine? Should we routinely be ordering TSHs with antenatal bloods, things like that?
Okay, all right. Let me know if I'm not addressing everything that's being asked. But
sure.
Yes, I am, as I'm sure all GPs are as well, very big on preconception planning. I would order thyroid function tests preconception and again in early pregnancy, and I would order a TSH, T4, T3.
Yeah.
I would not routinely order a TPO antibody unless there's obviously a family history or some clinical indication in the setting of recurrent miscarriage. And iodine, I do not check urine iodine levels. I would not expect, in the Western society with fortified, with iodine supplementation, that women should be iodine deficient. Obviously, it can occur, but ideally, we've got them on the pre-pregnancy multivitamin supplements anyway, from sort of 1 to 3 months, which should sort that out. And if there is evidence that they are iodine deficient, but they're already pregnant, or it's even in that preconception period and they're keen to try for pregnancy, I feel that thyroxine can do the job faster, to be honest. Yeah, to address that TSH level.
Okay. And there was a question with regards to someone asked in a private pathology, if you just order thyroid function tests, you only get the TSH if it's normal. Should we specifically be asking for TSH and free T4 to detect the isolated low T4?
Look, it's a great question. I mean, personally, I'm not a big believer in the isolated, low T4. So I wouldn't do it routinely to identify that. However, I do routinely ask, I would write the TSH, free T4, free T3. I mean, T3 arguably you don't need, but I do still like to see both together and then just see the longitudinal trajectory over time.
Okay.
Yep.
And then with regards to the sort of risks, I think you answered these questions subsequently, but they asked in terms of the reduction in fertility and miscarriage and things in conditions such as Hashimoto's, that's more linked to the thyroid antibodies rather than the TSH. Is that right?
Yeah,
Just
very much.
Yeah.
Yeah, very much. I mean, keeping in mind that your diagnosis of Hashimoto's is the TPO antibody positivity.
Yeah.
And particularly you'd want to see that TPO antibody being quite positive. So we're talking more than 100, in the hundreds.
Yeah.
Yep.
And with regards to calculating the weight for thyroxine therapy, do we use the pre-pregnancy weight or do we use the current pregnant weight?
Yeah, okay. Good question. I would base it on current weight and that 1.5 mics per kilo and just sort of round it up in general. Yep, that's what I would do. And then keep in mind that as the woman gains weight through pregnancy, particularly if it's overt hypothyroidism, I would anticipate that I need to increase the thyroxine during the pregnancy, not so much necessarily with subclinical.
Yep. Okay. And then with regards to once we've commenced it, someone asked a question, are we aiming for like the reference ranges? So like a particular type, you said less than 2.5 in the first trimester and less than 3 for a TSH subsequently. Is that correct?
Yeah, that's what I would do. Yes. Essentially, you just revert back to, if you're going to treat, then that you treat to a less than 2.5. And then, if you just think physiologically, the fetus is making its own thyroid hormone by 18, 20 weeks. So you don't need as tight control because again, unfortunately, we don't really know at what levels cross the placenta. So these are all quite gross guesses in some way, but the TSH as an assay appears to be most accurate with correlating with fetal outcomes. And that's why we use it.
Yeah. And when we do, someone asked, when we do a blood test, so an antenatal blood at 7 weeks, the TSH is greater than 4. So just to confirm, you would start thyroxine then and repeat the bloods in 4 to 6 weeks. That's the...
Yes.
Yep.
Yes, very much so. TSH greater than 4, absolutely.
Yeah.
Regardless of the T4, and you have that threshold for starting the TSH at a lower level if the woman is TPO antibody positive and or has had recurrent miscarriages.
Yeah.
And also, of course, I just say my caveat here is we're always very happy to help, and you can contact, Ash and myself or the RPA endocrine unit at any stage for this to give advice. Yeah.
Great. Just a couple more ones. So someone asked with regards back to the isolated low T4, if you get that, do you go on and investigate for other pituitary pathology? They just wanted to, should we be concerned about anything else?
No, I wouldn't. It's a fair point. And and I know what they're getting at. No, just because, you know, the prevalence of that isolated hypothyroxanemia, you know, I have to say personally, it's almost always an assay issue. And if you look at the data too, I know that, you know, then I've showed you studies in which they're trying to treat that. They've showed no difference in outcomes anyway. And ultimately, I think it's, does intervention make a difference? If it doesn't make a difference, then why are we even measuring?
Yeah.
But I think a lot of that is because those immunoassays in pregnancy are not accurate, and you tend to see this sort of leftward shift. So the T4 tends to be at that lower limit of normal, or sort of trending down, and it's 9 times out of 10 just an assay issue. So I wouldn't intervene, and I would just monitor it again. Yeah.
Okay. For a woman who's already been started on thyroxine for subclinical hypothyroidism but doesn't meet the TSH range or the TPO status, would you deprescribe during pregnancy? And if so, when? Or is it safe just to continue it through?
You know, it's a personal opinion. I would continue through. I just think certainly no harm. If you think about it, you know, up until recently, we were initiating for a TSH of less than 2.5. I think I would rather not have to. I think it's stressful to think, you know, we treated you for something and now we're going to stop it.
Yeah.
But it is personal. It is personal. And, you know, I tend to see a lot of those women from the fertility perspective who have been commenced on low dose thyroxine at pretty tight TSH levels. I probably wouldn't have commenced it myself, but no harm. I don't see harm, you know, particularly if you're monitoring the thyroid function test and you can see that the T4 and the TSH are exactly where you want them to be.
Yeah. Okay, great. So a couple more little ones. Is it, someone asked, can you have a thyroidectomy during pregnancy? That was asked during the Graves when you're talking about that. I assume you mentioned it later in terms of cancer. Would that be an option for someone during pregnancy?
So if you could avoid it, I would. And the reason why, it's a couple of things. I agree. While surgery is safe you can do it in the second trimester, I just think practically I'd be a little bit worried about titrating the thyroxine in the setting of the pregnancy. So I would still probably prefer, if we're talking Graves specifically, and they're very hyperthyroid and they're pregnant, I would just treat with medication. And you can often wean that medication pretty quickly, to be honest. And once you prove the TRAB is negative, if you start early on with the medication, you should be able to get them off that medication by the end of pregnancy anyway. So it's not a lot.
Yeah.
Yeah.
And someone asked, was euthyroid TSH less than 4, less than 2.5 preconception in the trials that you were talking about earlier? I don't know which.
Good question. I think I might have to look back at that. I mean, they always, I think, it varied. Maybe I'm not answering the question correctly, but it's when they sort of stratify, they'd always stratify, you know, a lot of that study I show stratified, and the problems, you know, the risks or the benefits particularly occurred when that TSH was more than 4.
4 anyway, yeah.
Yeah, yeah.
And the last one that I have is, what about all the women who are missed with the higher TSH? So I'm not sure if that's with regards to just in that sort of subclinical bracket, but I think then you went on to, this was early on, you went on to, you know, answer that there wasn't any specific evidence that there was a benefit. So I think we answered that.
Okay.
And then finally, is there a multivitamin tablet for preconception or pregnant women without iodine? I don't know.
Yes, I think you've got me. I don't think so. I could be wrong. I think I'd normally say in that setting, just take your iron supplement and your vitamin D supplement and avoid folic. Yes, yeah, that's right. Great question. I don't think so, but I don't know for sure. I don't know for sure. Yeah.
Okay. Thank you. That's all the questions I've got. Thank you so much. Really appreciate it. It was really helpful. So
no worries. Thank you so much.
Really appreciate it. Thank you so much.
My pleasure.
All right. And now, going to introduce our second speaker for tonight. Dr. Ying Li is an accredited fertility specialist with Genea, with consulting rooms in Sydney CBD, Hurstville and Walleye Creek. After completing his specialisation in obstetrics and gynecology, Ying completed further training in a subspecialist in reproductive endocrinology and infertility. Please welcome Dr. Li.
Thank you for asking me to speak. I'll just share my screen. Great, just checking. Yep, okay, great. So thank you for the introduction. I'm a fertility specialist based both at Genea and also at the RPA fertility unit. I've been asked to speak on obesity and fertility. This is a fairly big topic, and I'd probably like to just take a bit of a big overview about the issues involved. I would like to go through a few definitions, some very basic physiology, and then we move on to what are the effects of obesity both on male and female reproduction, and what are the outcomes of some of the interventions that we've looked at to try and help this condition. So I think if we just look at infertility, everyone defines infertility a little bit differently, but the definition that most of us take as sort of amongst the fertility world is that an inability to conceive after 12 months of regular intercourse. There are flexibilities to that dependent on a woman's age. Pregnancy loss, we define a pregnancy loss as loss of pregnancy after implantation or positive HCG. Implantation failure, this term is used a lot, but it really can only apply in an ART or an IVF setting. And generally, again, this definition differs between different specialists and centers, but we take it as transfer of 3 or more blastocysts, so day 5 embryos without a positive HCG. When we talk about live birth in these studies, we talk about live birth after 25 weeks, which is the WHO criteria, I believe. Ongoing pregnancy, again, a little bit different between countries, but the Australian Fertility Society defines that as an ongoing pregnancy after 12 weeks. And in terms of whether somebody is overweight or obese, we take the WHO definition. So BMR of over 25 is considered overweight, and BMRs of over 30 is considered obese. Generally speaking, in terms of what is the effect of obesity on reproduction, we know that there are definite decreases in pregnancy rates. There are definite decreases in ongoing pregnancy rates and decreases in live birth rate. Obstetric complications are every part of the obstetric journey, antenatal, intrapartum, postnatal. All of these complications are increased, as are pregnancy losses, especially in the first trimester. We know these complications correlate very well with BMI, and we also know that these complications can decrease with certain weight-based interventions. Just going through some of the physiology, I think this is certainly something that we teach to all our registrars and medical students, that reproduction is controlled by the hypothalamus, which then sends signals to the pituitary, which produces FSH and LH, which then sends signals to the ovary in the woman and the testis in the man, and there are negative feedback signals. So this is really as far as most of us seem to understand reproduction. But if we actually move higher up around the hypothalamus, the impact, the controllers around the hypothalamus and GnRH release, and therefore subsequently control the pituitary, is very numerous. And when we look at lifestyle, diet, and obesity, these are the hormones that we are interested in. Peripherally, we are interested in leptin, insulin, and ghrelin, and centrally, we are interested in kisspeptin, MSH, melanocyte stimulating hormone, and neuropeptide Y, which controls appetite and also has controls of GnRH centers higher up than the hypothalamus. Just talking a little bit about brain-gut interactions, I think when I was going through training, this is still relatively new, but we now know that fat tissue is not inert. It produces a whole lot of hormones, and the ones that are pertinent to this talk are leptin, adiponectin, and resistin. Leptin we'll talk about a little bit more in detail, abiraterone is an insulin sensitizer. Resistin essentially antagonizes insulin action. The gut also secretes its hormone that regulates appetite. Ghrelin is an appetite stimulant. PYY336 is an appetite depressant acting centrally on the brain. And the brain itself, as we saw before, produces a lot of hormones. And the main one here is neuropeptide Y, which controls appetite. If we look at leptin a little bit more, leptin is a peptide that is produced both by the small intestine and by the adipocytes. This is the hormone in satiety, and after a meal, leptin is generally very high. Leptin has also the ability to stimulate GnRH and therefore stimulate the pituitary and release of FSH and LH. We find leptin receptors not only on fat tissue and also in the brain, but also on oocytes and on the endometrium itself. We know that without leptin, implantation is affected. So leptin itself plays a key role in implantation. What we see in overweight people is that there is an increase in leptin level and a decrease in leptin sensitivity and leptin action. Ghrelin is a gut peptide. It is produced by specialized endocrine secreting cells in the gut, in the stomach. It surges pre-meals and it surges with fasting. It is a very potent appetite stimulant acting centrally on the hypothalamus via neuropeptide Y. It increases gastric motility, it increases carbohydrate utilization. In the reproductive sphere, we see this increased in polycystic ovarian syndrome, and we also know that at a central level, it suppresses pituitary release of FSH and LH, and therefore suppresses ovulation. If we put all of this together, and this is just a really nice diagram from an old fertility and sterility article, in an ideal state, with food intake or obesity, there is an increase in leptin, insulin, and PYY336, which is an appetite suppressant, which then leads to an appetite inhibition pathway that goes on in the brain. In the meantime, it also inhibits any appetite stimulation in the brain. And further on, if we then piece everything together in terms of what its effects are on the pituitary, so basically, as leptin increases, it will stimulate the pituitary to release more FSH and LH. Also, with ghrelin increasing, it will inhibit the pituitary's release of FSH and LH. The issue that we see in obese patients is that the leptin reaction is generally decreased, so there is less stimulation of the pituitary and therefore less release of FSH and LH, while the ghrelin action doesn't change, and in fact there is increased ghrelin action and active inhibition of FSH and LH secretion and therefore ovulation. Other molecules that are involved in the whole process, androgens, we know these are high in PCOS, and we know at an intrafollicular and oocyte level, if there is an imbalance of estrogen to androgen ratio, the competence of the oocytes are affected. Adipokinins are inflammatory markers that are produced by adipose tissue, and these actually damage reproductive tissue in oocytes and sperm. So if we look at obesity and how it affects female fertility, we think there is an effect on every level. So it affects the hypothalamus, pituitary, and ovarian axis. We know it affects oocyte dysfunction. We know that there is an effect on the embryo that is created, whether this is created naturally or in an ART or IVF setting. There is probably an effect on endometrial and implantation, but that effect is a little bit more controversial, and there's a little bit of doubt as whether IVF technology can actually overcome that. And there is an epigenetic or transgenerational effect, which we certainly see in animal models. So if we just look at what happens to that hypothalamic pituitary ovarian axis. In obese patients, their insulin levels are higher, they have high levels of androgen that feeds back onto the pituitary, and that's just a negative feedback. We also know that in fat tissue has excessive estradiol aromatization in the periphery, and again, negative feedback is increased, and this leads to anovulation. In obese people, there is excess visceral fat, leading to hyperinsulinemia, insulin resistance, and exacerbates the effects of PCOS in terms of its ovulation. What we find interesting about PCOS women and also obese women is that they remain quite subfertile even when they do ovulate. And that points to the fact that not only is this an ovulation issue, but there's an issue with probably receptivity, endometrium, and egg quality. As mentioned before, the higher leptin levels leads to a chronic downregulation of leptin receptors in the brain. This results not only in anovulation, but we think that it requires more IVF medication to overcome this effect. And generally, there are also lower amplitudes in LH pulses. I mean, LH pulsatility exists all throughout the cycle. I think we sometimes only think of LH as the LH surge around ovulation, but there are LH pulses in both the follicular phase and in the luteal phase, and the eggs really do need that LH to function. And when you dampen the amplitude of these pulses, then it affects things like oocyte competence and embryo quality. Apologies for this slide. This is very busy, but this talks about oocyte dysfunction and toxicity leading to lower oocyte competence. And what we mean by oocyte competence is its ability to function as an egg, ability to fertilize and combine with the sperm, the ability to repair itself. And we know that there are lots of mechanisms in obesity that inhibit this. We know that there are follicular fluid changes within the follicle itself, increased levels of insulin, increased level of triglyceride, increased levels of inflammation, which leads to the egg itself being not amazing as quality. We know the adipokinins potentially fragment the meiotic spindles in the eggs, and therefore some of these eggs will remain immature. As you know, eggs are halted in metaphase 2 when they are mature, and they only resume meiotic function or meiosis after fertilization. If the meiotic spindles are broken, so that doesn't really happen, or doesn't happen well, and we see more aneuploidy. At a mitochondrial level, there are changes in toxicity to the mitochondria. We know their morphology changes. We know they have high evidence of metabolic stress, and we know that they try and compensate for that by making more of themselves. We certainly find more copies of mitochondria DNA in obese women, but the individual mitochondria themselves are not very good. We also see cellular mechanisms such as the endoplasmic reticulum being stressed, and therefore the oocyte synthetic function is damaged. And generally, all these organella damages that we see, we think are probably due to an inability to store triglycerides. Triglycerides are normally stored in adipocytes, but when you have too much triglycerides, it overwhelms the storage capacity, and we generally get free fatty acids in the tissue itself. Free fatty acids are very good at producing reactive oxygen species. They deplete antioxidant levels. They lead to chronic inflammation, and we're now beginning to understand obesity from a point of view of inflammation, and certainly all the inflammatory markers, interleukins, TNF alpha, all of that are very high. And again, leptin plays a role. Leptin, we know, acts on oocytes. We know they act on eggs. We know they are, and we know leptin is needed to produce estrogen and progesterone. And we think that in decreased leptin sensitivity in obesity, that leads to decreased oocyte competence. Embryo effect, I think that makes sense. If you have less competent eggs, then you get bad embryos, and we see this at every stage. We think that they have less of an ability to metabolize glucose, and that's really important when an embryo hits around day 4 to day 5, when they switch from anaerobic to aerobic metabolism. We know that they have less cells in the part of the embryo that will ultimately become the placenta, and we know that in the cells that do have, they have increased levels of triglycerides. So on the endometrium itself, this is, as I said before, a little bit more controversial. The endometrium, the timing of the endometrium and implantation is extremely sensitive. So basically, the endometrium opens up a window of implantation where for about 24 to 48 hours, it expresses the receptors that match the receptors that are shown on the embryo. And if that window opens too early or too late, or the embryo doesn't have those complementary receptors, then the embryo doesn't implant and there's a negative pregnancy. We think that in obese women, the triglycerides themselves and also their reactive oxygen species will change that window of implantation and will actually actively inhibit some of the molecules that are really crucial for embryo docking into the lining. This really leads to not only decreased rates of implantation, but we think also higher rates of miscarriage of genetically normal embryos. And again, we know there are leptin receptors on the lining, and there's a role for proposed role for decreased leptin sensitivity in opening up that window of implantation. And finally, there is an epigenetic effect. So epigenetics is about the expression of genes rather than the genes themselves. Epidemiological data seems to suggest that overweight women give birth to kids who also have metabolic problems. We certainly see that in mice, that their genes, the genetic expressions change. They change in the placentas, and this comes across multiple generations. Okay, so moving on to obesity in the male, the effects are fairly similar. We know that it affects the hypothalamic pituitary testicular axis. We know there are peripheral effects of obesity. There are certainly functional effects. And at sort of the pointy end of things, there are changes to the semen. And again, just like the female, there are epigenetic and transgenerational changes. If we look at the hypothalamic pituitary testicular axis, production of sperm by the testicle, one of the prerequisites is that there needs to be intratesticular testosterone, and that is stimulated by LH pulsatility. And we know that in obesity, for a whole number of reasons, that pulsatility is reduced. These testis also becomes less sensitive to LH pulsatility, and that leads to decreased levels of T, especially intratesticular testosterone. Increased levels of fat increases aromatization, and there is increased levels of estrogen, so the testosterone to estrogen level ratio is out of whack. And all of these things will alter the ability of a testicle to produce sperm and the quality of the sperm that is produced. Interestingly, there is a role for kisspeptin here. So kisspeptin is the molecule that has only been relatively recently discovered. We think that kisspeptin plays a really important role in puberty, and certainly without kisspeptin, we see children not able to go through puberty. What we see normally is that in adipocytes, they release leptin, which increases kisspeptin, which then increases GnRH and increases FSH and LH. In obese people, in obese men, we found that this pathway changes. We know that increased estrogen will downregulate kisspeptin, and chronically elevated leptin levels will basically blunt this pathway. So again, affects secretion of LH and also FSH. At a peripheral level, you have insulin resistance, you have decreased production of sex hormone binding globulin, which leads to increased free testosterone, which leads to increased estrogen and magnifies that central negative feedback. We know that obese people are more likely to have sleep apnea. There's now quite good data that links sleep apnea to a whole range of health effects, but also semen analysis parameters. And we certainly think that intermittent hypoxia affects gene expression, and also it affects the motility of the sperm. In addition, these obese patients have an accumulation of what we call endocrine disruptors, so chemicals that bind and react to endocrine receptors, and they have a whole range of effects that are fairly negative. And at a very basic level, we know that the scrotum has a temperature that is 1 degree lower than the rest of the body. If you have excessive adipose tissue there, we see in some patients that thermoregulation ability is gone. So the testicles are actually hotter than they need to be. On a functional level for men, certainly sexual dysfunction is worse. So there are some studies that says it's about 30% worse. There is high levels of erectile dysfunction. The pro-inflammatory state leads to more endothelial dysfunction, and there is the general deficiency in testosterone level, which affects things like sexual drive. And I think if we just look at what happens in the semen, meta-analyses have shown that really oligospermia is significantly increased if a man is obese. Stenospermia, so sperm that doesn't move, is increased. And we also look at the DFI, so the DNA fragmentation index, which measures the percentage of sperm that has broken DNA in its head. And we know that this is also increased in obese men. Interestingly, there is a decreased telomere length in the chromosomes, in the chromatin, in the sperm, which we think is related to this DNA damage. Telomeres are structures in the chromosomes that protect DNA from degradation. And same as the female, epigenetic and intergenerational effects are definitely seen. So we know that there are changes in the acetylation, so the changes in acetyl groups in chromatin. In sperm, we see changes in microRNA and non-coding RNA. And certainly, if we look at animal studies, the cross-generational obesity seems to be inherited by their offspring from obese fathers. So if we look at going back to ART, and as an IVF specialist, this is something that we get asked about a lot. So what are the effects of obesity on IVF? So again, this is one of those things that almost at every single IVF parameter, obesity has a negative outcome. The number of eggs are lower, the quality is lower, the embryo that results, you get fewer of them and they're poorer quality. The stimulation is harder, so they need more medications, higher dosages for longer. The egg collection, the procedure is much more difficult. The pregnancy rate is lower, ongoing pregnancy at live birth, they're all decreased, and increases in implantation failure and pregnancy loss. So this has been well documented in observational studies. So if we look at some of the interventions, the trouble with all of this evidence is that, like a lot of issues in fertility medicine, the trials that have been done are very small. They're underpowered. They have really high cancellation rates. But what we do see is that weight is significant, and it's not, you don't need to lose a lot of weight to gain some benefit, whether it's returning of regularity period or returning ovulation. The few small studies that have done can show up to a 3-time greater intervention over an 18-month period in terms of their fertility outcomes. So, I mean, what these studies tend to show is that you not only need to lose weight, but you need to maintain that weight loss for a long period of time. There seems to be slightly less impact on miscarriage. Ovulation and menstrual regularity is probably the big data field that shows improvement, as do assisted reproduction outcomes. Exercise, we thought initially that exercise was very favorable. There are some trials that says, yes, in spontaneous pregnancies, this is increased, But there are also trials that say that if you have excessive exercise, so over 4 hours per week for 9 years, so there are trials that looked at people who exercise intensely for over 4 hours per week over 9 years. They generally then had really negative impacts on ART. So they certainly had more cycles that are unsuccessful or cancelled, and they had lower chance of live birth. So the exercise evidence is not entirely convincing. In terms of dietary sort of interventions, again, apart from the usual things, vitamin C, E, D, iodine, folate, the one piece of data that seems to say makes a little bit of difference are the antioxidants. Most of the evidence from antioxidants in both obesity and people of normal weight comes from coenzyme Q10, and a lot of this comes from animal models rather than human models, but they do certainly improve egg quality and improve ovulation, and a lot of my patients are just on it, especially if they are overweight. And we think that probably calorific amount is not the entire story in obesity. There are some studies that show that the Mediterranean diet seems to be beneficial from a fertility perspective, and certainly it decreases inflammation. I just want to touch briefly on bariatric surgery for the female. I know this is an increasingly available field. The evidence for reproduction is still a little bit sparse. We certainly know that bariatric surgery, so both the sort of the more interventional, the big bypasses, and also the sleeves, these are definitely associated with increase in weight loss. They definitely shorten the follicular phase, and they certainly do increase menstrual regularity and ovulation, and they have quite positive hormone profile. What we also see, however, is that they do increase the rate of IUGR, and there are trends towards increases in things like small gestational weight, stillbirth, neonatal death, PPROM, and preterm delivery. But on the other hand, some of the other sort of intrapartum bad outcomes like preeclampsia, GDM, PPH, cesarean section rates do decrease with bariatric surgery. So the recommendation for bariatric surgery is still to have it, but then wait 12 months before conceiving. And we think some of these negative effects are basically from the malabsorption that happens after a rapid weight loss in bariatric surgery. This is another medication that I get asked a bit about, the GLP-1 agonists. So the glucagon-like protein agonists. They're basically something called an incretin group. So they act on GLP-1 receptors. They can be used in the context of obese patients with polycystic ovarian syndrome. It works by increasing insulin release, drops the sugar, maintains normal BSL. But we also know that it also protects the endothelial a little bit as well. There are certainly studies that say that their blood pressure parameters are improved. Their menstrual regularity is increased, as are their ovulation events. And there are also weight loss benefits to that as well. Apart from that, it hasn't really been studied as much in an IVF setting, but only really in a PCOS setting. If we just move briefly to the males, so diet and exercise do improve things in the male. The weight loss do lead to improvements in semen levels, testosterone levels, erectile dysfunction, even mitochondrial function and epigenetic profile. There are people who have tried pharmacotherapy to try and increase the testosterone level, and this is normally in the form of clomiphene citrate and aromatase inhibitors like letrozole and anastrozole. I have to say, I don't use them myself unless somebody is azospermic, where you can try to shift the testosterone to estrogen ratio a little bit. Again, a little bit about bariatric surgery in the male. Certainly very successful in treating morbid obesity in the male. In azospermic men, so azospermic pre-surgery, we do see an increase in count of sperm and increase in testosterone level, and the two are, I'm sure, linked. In terms of motility, morphology, and DNA fragmentation, the results are more mixed. So there are some results that say that it improves all of these parameters, but other results say that due to the decrease in absorption, sort of some of these parameters, especially the DFI, so the DNA fragmentation index, is it actually gets worse for a little bit. What we do see is increases in libido and sexual function. We do see increases in pulsatility in LH and FSH. What is a little bit sort of unknown is what are the effects on the offspring born from men who are overweight and then have bariatric surgery. We do think that there are differences epigenetically, so the methylation and expression of genes do change in the offspring, but we also see that there are improvements in signaling of that gut-brain fat tissue interaction, things like leptin and insulin. So I think I've gone fairly quickly over this, but generally what we say is, just to conclude, obesity is negatively correlated with fertility for both males and females. It correlates quite well with BMI, and there are definite obstetric factors, and the college at Ranscog does put a BMI cutoff around 35. As somebody who goes over that should lose weight before they try and conceive. Weight loss can have positive effects on fertility, but the evidence for exercise is a little bit contradictory. Some of the newer forms of therapy, things like bariatric surgery and Glp-1 agonists, probably do need a bit more study before we can say that this is definitely something that can be used for people who are obese and have fertility issues. And with that, I will open up to some questions.
Thank you. That was great. We've got a few questions here. I'll cluster a few with regards to men. The vitamin Elevate for men, does that improve sperm quality, or is that something that's just a marketing sort of thing?
So Kelton Tremelin, who is the guy who he works for an IVF company in Adelaide, he made up that formula. So it's called Menavit rather than Elevate. Mm-hmm. It probably is the antioxidant that has the most evidence behind it. So what it is an antioxidant. It contains vitamin E, C, and zinc and selenium and a whole range of other stuff and garlic and things like that. So there is some evidence that there is an improvement on especially things like DNA fragmentation and DNA integrity in the sperm. My advice to my male patients is any antioxidant will do. So all the men's health antioxidants, as long as they have vitamin E, C, zinc, and selenium in it, then they should take it. You don't necessarily need to take Menavit, but it is the most convenient formulation that's out there, but it's also the most expensive.
Yeah. Okay. And is there any cutoff for males in terms of BMI for IVF, assisted reproductive? I don't know if for females there is, but
yeah, there isn't, and this is a debate. So when we have our meetings, when the CREI subspecialists meet, we always have this debate. As I say, this is a bit of a double standard, and the reality is that the negative outcomes in gametes we see in females, we also see in males. And that's something that nobody can deny. I think the issue with the males is that they don't need to then carry a child, and also men can have interventions that can act on a brand new batch of sperm after 70 to 90 days, whereas women can't. Those eggs are there. But this is definitely an ongoing debate, and I wouldn't be surprised if at some point there will be some guideline that says that these are the recommended BMIs for men undergoing ART.
Yeah. Okay, that's interesting. And then a couple of questions with regards to the GLP-1 agonists. How long before should they start, and how long should they cease it before they start trying for pregnancy?
So no one knows really the answer to that, and we're still trying to sort of grapple a little bit with this. We generally would say that this should be stopped before they start trying, because we don't know the effects. We have no long-term data on babies on GLP, and certainly for our IVF patients, we get them to stop it before they start FSH injections.
Yeah. Okay. And someone said, thank you for the fascinating talk. Apart from reducing obesity in our patients, is there any emerging therapies on the horizon for leptin?
There are lots of emerging therapy, nothing that I have seen that has been in a big clinical trial. So this is an ongoing field of research at this point in time. Yeah.
Okay. What does chemical pregnancy mean? Someone asked.
Yeah, so I think we're trying to get away from that. Chemical pregnancy is somebody who has a positive HCG, and nobody can agree on where that HCG is, like a beta HCG on serum or a urine HCG on just a urine test. But it's a positive HCG without an ultrasound confirmation of pregnancy.
Yep. And the last one I've got is for, this is more of a general question. For patients who are Rh negative blood group with early miscarriage, would you still give anti-D?
So I suppose you weigh up the pros and cons of giving anti-D, and I think most of us would err on the side of giving it, but at that smaller dose.
Yeah, that's all I've got, unless anyone has anything else. But otherwise, thank you. That was very fascinating. We appreciate both of you for your time tonight.